Thank you very much. I'm very honored to be here. It's my first time in independent in Lithuania, so it's also another emotional feeling here. But I'm supposed to tell you a little bit about multiple myeloma, which is neoplastic disease of B-lymphoid parts, that is from the point of view of current WHO classifications belonging to B-cell lymphomas, but as all neoplastic disorders are this clonal disorder, which is meaning that is originating on the level of a single cell, which is becoming founding cell, and actually is then the subject to further genetic modification that occur both spontaneously or sometimes also induced by the treatment. And it is important that this neoplastic cell and its progeny, they are producing single antibody, which is single from the point of view of antigenic specificity, and it is then called monoclonal antibodies. Besides, not always this antibody is a full antibody molecule, but sometimes only part, either heavy or more frequently light chains of these antibodies. And sometimes there's this production of both full antibody and only light chains. And then this is quite interesting because on protein electrophoresis there are two peaks of protein, which does not mean that this is biclonal disease, but it is the same clone which is producing these two products. And just to remind you that antibody looks like letter Y, and these are so-called heavy chains, and they are adjacent to its light chains. And then, since I am supposed to tell you about how complex is multiple myeloma, so first type of complexity could be structured according to the type of antibody that is being produced, which could be IgG type, which is most frequently, then IgA less frequently, but very rarely could also be IgD or IgD, and also sometimes IgM. This has to be differentiated from Waldenström macroglobulinemia, but also there is such thing as IgM multiple myeloma. Very rarely also this malignant plasmacytes may not release protein, and this is called non-productive myeloma. And as I have mentioned, sometimes there are only light chains produce either kappa or lambda types and not the full antibody. So actually, the title could be modified to be heard as plasma cell dyscrasias, because actually there is quite a spectrum of disorders that are produced by malignant plasmocytes, and they start from monoclonal gammopathy, but which is by itself not considered something that will require treatment, similarly smoldering myeloma, and then there is fully blown plasmacytic myeloma. The most advanced stage of this is plasmacytic leukemia, but it also could be the so-called primary amyloidosis, light chain deposition disease, and Poyens syndrome, and I will elaborate this a little bit later. Generally, even if somebody is not suspecting myeloma, it is quite important to perform at least once a year 3 simple tests, which are including complete blood count, erythrocyte sedimentation rate, and urine analysis. And this will actually may point out that somebody is suffering from either myeloma or preceding pathology like monoclonal gammopathy. And of course, if something is abnormal, then there is a necessary diagnostic procedure. But even if not just doing this on routine yearly manner, if patient is referred to the doctor because of back pain, general worsening of the condition, behavioral abnormalities, fever, weight loss, other unusual symptoms, it is also important to repeat this test, because abnormal results may actually lead to the diagnosis of myeloma. And one has to remember that normal erythrocyte sedimentation rate could also be associated with multiple myeloma. This is situation when there is only light chain disease, and when there is kidney injury, actually abnormal protein is being removed with the kidneys, and this is not manifested by protein electrophoresis. This is why it is important to include in this free test urine analysis, because then this abnormal antibody will be actually identified in this analysis. Multiple myeloma is example of neoplastic disease, and as all neoplastic disease has consequences that are secondary to the excess of neoplastic cells. So they could be either intramedullary tumors frequently associated with bone destruction, or more rarely extramedullary tumors. But it's unique in this term that also a lot of pathology is actually created not by the presence of cells, which are sometimes even difficult to find out, but by the products of the cells, and they could be simply excess of this product, and this will create symptoms which are called hyperviscosity syndrome, or if this is light chain disease, more frequently kidney injury, then the cells are also producing various factors, such as IL-6 and other osteoclast activating factors, which are contributing to bone destruction. And also they could produce factors like vascular endothelial growth factor and other growth factors, which is then responsible for something which is called Poems syndrome. And not only this is a problem that this is only excess of this protein, but also this protein could produce pathology by deposition in various tissues. And the most dangerous situation is that this deposited protein is changing conformation from beta helix to alpha from alpha helix to beta sheet, and this is then leading to a condition which is called primary amyloidosis. But it could also be this protein deposited without changing in conformation. It's called light chain deposition disease. So already this is such huge spectrum of pathology that could be seen. And from the clinical point of view, one should differentiate the situation with and without kidney injury. And of course, kidney injury usually is not occurring when there is no protein product, or when there is full antibody produced, or when there is heavy chain produced only. But if this is only light chain produced, this is actually quite routine that it is present. And if there is defective light chain that is leading to primary amyloidosis, also producing kidney injury, but slightly little different mechanism than simply light chain overproduction. Moreover, one can structure multiple myeloma from the point of view of genetic lesions that actually are on the background of neoplastic behavior of the cells, and these changes could be divided into so-called primary genetic changes, or changes associated with disease progression, which are overlying on this primary changes. And from these primary changes, one can divide multiple myeloma into so-called hyperdiploidal myeloma, which is approximately 45% of all myeloma, which is usually IgG kappa. And considering older patients, has usually slightly better prognosis than a non-hyperdiploidal myeloma, which is approximately, again, 40% of all myeloma is usually IgA lambda, younger patients, more aggressive disease. But then as far as this hyperdiploidal myeloma, one could identify those patients which have chromosome 13 deletions or abnormalities of chromosome 1, and without these abnormalities. And this non-hyperdiploidal could include hypodiploidal, pseudo-diploidal, near tetraploidal karyotypes, and frequent IgH translocation. And still 15% myeloma do not fall into these two major categories. And just to explain what this strange terms means, that hyperdiploidy means that there is more than 46 chromosomes, hypodiploidy less than 46 chromosomes, pseudo-diploidy 46 chromosomes, but deletion of one is corrected by trisomy of the other, and near tetraploidy is above 75 chromosomes. Then there are trisomies of chromosome uneven chromosomes, so it's 3, 5, 7, 9, 11, 15, 19, and 21, easy to remember, and monosomies of chromosomes 13, 14, 16, and 22. These translocations are three measures that could be considered. 11-14, which concerning 15% of myeloma, and including IgM myeloma and amyloidosis, so it's actually bad. Then 4-14 translocation and 14-16 translocation. All these translocations are associated with IgH rearrangements, so these are genes for immunoglobulins. So then on the background of this, we have then secondary genetic events, and this is deletion of chromosome 13. Then there is deletion 17p, roughly similar to something what is happening in chronic lymphocytic leukemia, and also is a worsening prognosis when it occurs. Abnormalities of chromosome 1, NF-kappa B activation, mutation KRAS, deletions, and so on. There are still, the list is still not complete. So from this translocation 4-14 and 14-16 are associated with poor prognosis. Monosome 13 is again poor prognosis, and moreover it is resistant to transplantation, but not resistant to bortezomib. Of course, deletion of 17p, as I have mentioned, is poor prognosis. Also, disturbances of 1q and 9q worsen prognosis. Well, the role of translocations 11-14 are less clear, but of course, if this is associated with amyloidosis, also is worse prognosis. So, on this basis, one could define risk categories into standard risk and high risk, and of course these categories differ significantly in projected survival. So this is how this process of disease is coming. So it is not so that, first of all, this process will always be completed in every patient. Actually, majority of patients stop on monoclonal gammopathy and never develop multiple myeloma. The risk of progression of monoclonal gammopathy to full-blown myeloma is about 1 to 2% yearly. So if disease, the median occurrence is 69 years, it means that vast majority of patients have no chance during their normal lifespan to actually progress to multiple myeloma. But if this will occur in either of two scenarios, these two major scenarios, then the situation in patients, even without treatment, would depend on the occurrence of the secondary events, which will change the prognosis from this that is defined by primary, also called founding mutation, and is then leading to more aggressive treatment, eventually to progression to plasmacytic leukemia, which is the worst, most advanced stage of this type of disease. Generally, in order to define this genetic risk factors, it is necessary to perform analysis, and more important, it should be rather performed at least by FISH testing if more advanced techniques are not available. So these are this more advanced test methods, such as comparative genomic hybridization of GEP. They have still not yet fully established routine use, but it is something that is coming while FISH analysis is now routine. Generally, coming back to the explanation of the disease, this is, let's say, a general picture of regulation of cell behavior by the organs. So it starts from cytokine receptor through signal transduction molecule that transform information from activated receptor through cytoplasm to the cell nucleus, activate transcription factor, and this, of course, initiate transcription. And if the transcribed product is cell cycle protein, of course, it would lead to cell division. If this is functional protein, it would lead to of course, appropriate differentiation, and these proteins are finally destroyed by proteasome. Actually, all genes of all this pathway could actually lead to either occurrence or actually also to aggravation of the course of multiple myeloma. So this could be either be genes activated for various growth factors or growth factor receptor or signal transduction molecule or transcription factor, and also genes for cell cycle proteins such as cyclin D1. So one can actually develop a general model of progression of neoplasia, which of course starts from founding mutation, which usually is not just mutation that is actually producing neoplastic behavior, but it's actually producing so-called proliferative advantage. So for the next generation, this mutated cell is competing more effectively with cells that are not mutated, and then it may be another event occurring, and then there will be three stem cell populations competing for the next generation. This will be non-mutated cells, cell with one mutation, cell with two mutations, of course. Then the winning population will be cell population with two mutations over normal cells and cells with one mutation, and then fourth mutation may occur, and this will be associated with further progression of disease. And if this is applied to myeloma, this first mutation will result in monoclonal gammopathy, the second mutation is Smoldering myeloma, then third mutation with plasmacytic myeloma, and the fourth with plasmacytic leukemia. And this means that if we need to consider how we would treat multiple myeloma, we have to think about actually not just one myeloma stem cell population, but actually with multiple subclones within a single patient. Also, we sometimes, if we analyze this, we just see only one dominant stem cell population. Does not mean that this is the only subclone. It's only saying that this subclone has proliferative advantage over other subclones which may emerge when we destroy this particular subclone. So actually the model that I have just shown you could also be simplified in this terms, that they may be on this level of second or third mutation in different subclone superimposed on different secondary mutations. So there will be actually within the same disease two or three pathways occurring more or less independently, and we then have actually multiple myelomas in the same patient. So if we will apply therapy, of course the dream result is that we will cure this. So then we will eradicate all these mutant cells. We actually will be satisfied if we just leave the cell with one mutation, because this is this monoclonal gammopathy. So in a way, for most of these patients will be operational cure. But actually, most frequently, we are receiving something like this, which is partial remission, that we essentially eliminate the most advanced, most aggressive cells, because they are usually more sensitive to chemotherapy or immunotherapy or various other modalities that we now use in myeloma. But unfortunately, sometimes we may select more malignant cells, and then this is a course that is associated with rapid progression of disease after treatment. So there could be actually quite good immediate results, but then very aggressive relapse and progression. Sometimes we can actually select one subclone over the over the other, or then actually the subclone will be expanded and eventually may kill patients. The main question in this group of diseases, of course, is to treat or not to treat. And generally, all these types of disorders require treatment, except for so-called pure monoclonal gammopathy and smoldering myeloma. And which monoclonal gammopathy require treatment. Of course, this that are associated with light chain, and this is with either amyloidosis and heart involvement and with renal involvement. So they are now subclassified as different variations of this situation. Generally, we these days follow criteria developed by International Myeloma Working Group, and that are criteria that differentiate monoclonal gammopathy of unknown significance, smoldering myeloma, and multiple myeloma. And actually, there are so-called CRAF criteria, that is criteria related to calcium elevation, renal insufficiency, anemia, and bone disease. And if this or any one of these criteria are met, this is a disease that requires treatments, while the other disorders require so-called wait and watch strategy, that is actually visit between 6 and 1 month at 1 month distance, just to check whether there is or there is no progression. Because even within smoldering multiple myeloma, one can differentiate two different subgroups that are behaving a little bit different. So they are shown on this slide. So some of this will progress very early, some of them late, and so they will require different intensity of our attention in order to pick up, to find out appropriate moment to initiate the treatment. These days, a very important diagnostic test is free light chain measurement, and particularly determining free light chain ratio. And depending on this ratio, this decision could be made into this smoldering multiple myeloma, which may require treatment, or this one that is still only needs observation. Multiple myeloma is most of the time incurable disease, and I have slightly modified this drawing that was developed by Brian Dury in this sense that he has stopped on one of these relapses. And actually, if we are these days dealing with multiple myeloma, which is not curable disease in most of the cases, because there are some cases that are cured by allogeneic stem cell transplantation, but there are very few. So this is actually going into a treatment requirement, not just for the second line, but for the third line, fourth line, and probably so on, because these people are living longer and longer, and hopefully they will soon, well, not soon, but within years, reach the normal expectancy. Then the next question is to transplant or not to transplant, and of course then the decision whether patient is candidate for transplant depends largely on age, but age is not any longer considered the only parameter over which we judge the decision, but another, probably even more important, are comorbidities, this serious either heart or renal or liver abnormalities will exclude patients from transplantation. Then, of course, the choice of treatment depends on availability of methods, because, of course, in some countries there is limited access to transplantation. then there are about 10, 15 myeloma patients are patients who are on dialysis. There may be transplant service, but not transplant service that will transplant dialyzed patients. So then these patients will not have access to this treatment modality. Then, despite the fact that we have now registered in Europe many drugs, many of them may not be reimbursed, like in Poland, still pomalidomide, panobinostat, ixazomib, carfilzomib, daratumumab, and elotuzumab, as well as lenalidomide first line are not reimbursed. And then we also, as Anita already said, we have to listen to patients, and not patients are either to go for transplantation, particularly if patients are 70 and some already disease history. So this is something that I have already mentioned. This is just showing that this is also more common judgment, not just myself. So then the initial approach is to whether there is transplant candidate and non-transplant candidate, and I of course will not go into transplant candidate because this will be next lecture. Essentially, for these elderly patients, traditionally the treatment was based on oral melphalan, so-called MP combination, that is a combination of melphalan with prednisone, which has been then modified by adding thalidomide, and that's actually already significantly extended overall survival, and these treatment modalities are more and more modified, and they are now based on these other drugs that are available, particularly lenalidomide and bortezomib, and they constantly improve survival also in this subgroup of patients. However, one has to remember that in these patients, the dosage of these drugs, depending on the age and comorbidities, has to be reduced because they may be overwhelming or over-toxic for this group of patients. So there are also drugs that are waiting for being introduced, which I hope that will extend further progress in survival that we have already achieved, and these are proteasome inhibitors such as carfilzomib, ixazomib. Ixazomib is particularly interesting from the point of view of this non-transplant candidate because it's oral, so it actually can shift treatment to outpatient fully, while for bortezomib patients have to come to the hospital. Then monoclonal antibodies will also make probably the most innovative of this drug because they use different mechanisms of action than the other one, like proteasome inhibitors are just something that mimic earlier introduced bortezomib. Immunomodular pomalidomide has advantage over both thalidomide and lenalidomide, but is also belonging to this group of drugs. And panobinostat is also probably has some place in this treatment, probably not really comparable to, let's say, the daratumumab. So what are the progress and challenges? Progress is that we better understand the disease. We made significant improvement because of availability new effective therapy and the introduction of constantly new combinations actually prolong survival. And something that I did not mention, we also make very significant progress in the control of adverse events and comorbidities. Of course, multiple myeloma has many of these secondary consequences, such as bone lesions, and we have made progress as medicine also in this respect. But again, the disease is still incurable, and this is disorders that after being advanced actually very significantly decrease quality of life, and we still need new treatments because we need to achieve new remission, and this usually has to be achieved with something that is exploring novel mechanism of actions. And actually, if getting few words about the situation of Poland. So in Poland we have approximately 1,300 new cases of myeloma per year. And in year 2000 we had altogether in Poland 3,600 myeloma patients. In 2013 we have more than double this number. And this is due to the introduction of this new drug and, of course, widespread of bone marrow transplantation in multiple myeloma in Poland. And, of course, we hope that in a few years we will reach this 10 years of survival on the average. Thank you very much.